بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. بسم الله. بسم الله. لا. بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله.
بسم
بسم الله.
الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله.
بسم الله.
بسم الله.
بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم
بسم
الله.
الله الرحمن الرحيم.
بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. هو ده اللي بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. بسم الله.
بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. بسم الله. بسم الله. بسم الله.
بسم الله. بسم الله.
بسم الله
بسم
الرحمن الرحيم.
الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله.
بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله.
بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله. تشيك تشيك مايك. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. تعال عشان انا قدام كده. بسم الله. بسم الله. مظبوط كده.
يا عم انت ما بتزعقش. بسم الله الرحمن الرحيم. بسم الله. بسم الله. وحد يزعق زي كده وهو بيتكلم. لازم لما تيجي تشيك المايك
لما انا
تتكلم
كلمته
برا.
كده.
العالم بتتكلم ازاي؟ بسم الله. بسم الله. يزعق لي وبعد بيتكلم زي كده.
الصنم الصوتية.
بسم الله. بسم الله. بسم الله. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. 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 بسم الله الرحمن الرحيم. بسم الله. بسم الله. بسم الله. بسم الله. بسم الله الرحمن الرحيم. بسم الله. شيك مايك. شيك مايك. أعوذ بالله من الشيطان الرجيم. صلى على رسول الله عليه أفضل الصلاة والسلام. اذكروا الله، لا إله إلا الله. ولا حول ولا قوة إلا بالله العظيم. بسم الله، بسم الله الرحمن الرحيم. بسم الله، بسم الله، بسم الله الرحمن الرحيم. بسم الله. شيك مايك شيك. بسم الله الرحمن الرحيم. بسم الله، بسم الله، 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 بسم الله، بسم الله الرحمن الرحيم. بسم الله، بسم الله. بسم الله. بسم الله، بسم الله الرحمن الرحيم. بسم الله، بسم الله، بسم الله، بسم الله. وحدوا. بسم الله. يا حديد قديم بلاستيك قديم للبيع. يا حديد، اوعى تمسح اللي عندك. العالم تعبانة فيه. طالما طجشت دماغك كده يبقى على العوض. بسم الله، بسم الله، بسم الله، بسم الله الرحمن الرحيم. بسم الله. قلت لك طالما طنجش ودنه يبقى خلاص خربت يا حودة. اطلع لي بقى على المزمار البلدي يا جدع.
صباح الفل.
ايوه البت جايه من النوم ما معرفش الا حمزه بتحلم بيكتر الله. صباح الفل يا معلم. صباح الفل. اطفي من عندك.
صباح الفل، كيف حالك؟ شو اخبارك؟ ان شاء الله طيب، شو اخبارك؟ ان شاء الله كويس. Good morning, everyone. I really, first of all, I would like to thank you for being first, the early bird coming to the conference. Second of all, on behalf of the Johns Hopkins Aramco Healthcare and the Saudi Cancer Foundation, I would like really to congratulate all of you and all of us, honestly, for a very successful first day. We had yesterday 5 sessions, 3 of them were on breast cancer and 2 sessions on gastroenterology tumors. And today we're starting our second day, and hopefully it's going to be more exciting and more challenging. Also, some of the topics that we're going to cover today is genitourinary tumors, lung cancer, other hot topics, and health policies. So I would like to thank you all and ask the moderator to come to the podium. They're all excited and to start the second day. First speaker is going to be Dr. Abdullah Sham.
Thank you, Dr. Nafis Al-Faris. Really, we had a wonderful day yesterday, and I have no doubt we'll have another wonderful sessions today. So starting the GU sessions, we'll be hearing about, in the first presentation, about metastatic castrate-resistant prostate cancer, state-of-the-art management in 2018. And if it's state-of-the-art, it should be Abdullah Shurb who present, because he is really the best one to present about this topic. Dr. Abdullah Shurb is a dear friend and senior oncologist in Riyadh, King Fahd Medical City. He has great experience in GU and GI cancers. He doesn't really need more introduction to such audience. Dr. Abdullah, تفضل.
Thank you so much, Fahad. To start with, Assalamu alaikum jami'an. It's my pleasure, Dr. Nafisa, to be with you today, and thank you so much for organizing this activity. And special thank for the chairman sessions for the nice introductions. So to start with, I would like to assure you that prostate cancer only happens in male, and it does not catch the female, and this is a good news today. So prostate cancer in Saudi Arabia, it is not very common. It's not one of the top 10 cancer in Saudi Arabia. However, in male, it's number 6 with almost 306 patients per year, and we are expecting year by year that we have increasing in the numbers. So it is not one disease. It is a spectrum of disease, starting with the localized, and then hormonal sensitive, then castrated resistance, and as you can see clearly, the survival was dropped dramatically from 95 to 15% in castrated resistance prostate cancers. However, in the last 20 years, there is a tremendous improvement in overall survival. Everyone remember the 1999 of Dr. Tannock trial, when he looked for mid-Xantron chemotherapy, and there was no survival benefit, and the drug was approved based on something called clinical benefit, which is actually controlling the weight, good performance status, and controlling the pain. Then subsequently now, we are reaching to almost 35 in the first line of therapy. And as you can see, we start with a 12-month initially, then in the last 2 or 3 years, it does not reach to more than 5 years, the survival. So the definition of castrated resistance, there is a lot of debate about the definitions. However, currently, I think the consensus is you should have castrated low level of testosterone, and one of the two, either biochemical progressions or clear radiological progressions. But in spite of this tremendous improvement, metastatic castrated resistance is still an incurable disease. And most of the patients, they will develop resistance to the treatment, and always we are welcoming any new medications. So you remember the mid-Xantron trial, as we said before, it showed only improvement in clinical benefit, and there was no overall survival. And in spite of this, it's become the standard of care. until 2004, when two important trials published in New England Journal of Medicine by Dr. Tannock and Dr. Petrylak, which showed docetaxel chemotherapy improved the survival for the first time. And based on that, the consensus from ISMO, AOE, NCC guideline, ASCO, was the 75 milligram per meter square every 3 weeks is the standard of care. And remember, it's only 3 months survival benefits. So castrated resistance prostate cancer, the fundamental treatment actually, it is the docetaxel chemotherapy. However, one of the major concerns that, as you can see in this trial, and we are seeing this in our clinic, some of the patients, they cannot receive the chemotherapy. And as you can see in this retrospective analysis, those whose age less than 70, only 61 they receive chemotherapy, and definitely decrease to 30 and decrease to 5 in those patients who has more than 80. And the first important medication came from the shelf was actually abiraterone, which is CYP17 inhibitor. And basically, it inhibits the formations of testosterone in testis, adrenal, and the prostate. So it works centrally and works on the peripheral way. And the first trial was abiraterone, which is 302, where they compare abiraterone and prednisolone in progressive patients who's asymptomatic patient and no visceral metastasis to placebo, and based on the trial, showed clearly overall survival was almost 3 to 4 months. The second trial, actually, the enzalutamide, and enzalutamide, it is again androgen receptor inhibitor, and it's basically impaired the nuclear translocations and ultimately block the DNA binding and activations. And enzalutamide was examined in pre-field trial, phase 3 trial, and as you can see, all of this trial was published in New England Journal of Medicine. Again, same identical patient, progressive patient, that on hormonal therapy, they were randomized to enzalutamide or placebo, and in patient asymptomatic or mildly asymptomatic. However, in those trials, they did include the visceral metastasis, and you remember in the abiraterone, they did not include the visceral metastasis, and despite of this, it showed tremendous improvement in overall survival as well as the progression-free survivals. So, both of those two medications, which give us an overall survival benefit, both of them giving progression-free survival, good PSA response, and significant delay to cytotoxic chemotherapy, and clearly delay the duration of life, duration of quality of life. So you remember docetaxel was the basic medications and standard of care in castrated resistance. However, enzalutamide and abiraterone was used as a pre-docetaxel chemotherapy, and it's becoming approved now for any patient with castrated resistant prostate cancers. However, the big question came, what if the patient has docetaxel progressions? What we should do? And it was a big concern till we have 3 important trials. The first one was a tropic trial, cabazitaxel, which is exactly like docetaxel with some change in terms of the receptor. BGP receptor is usually attacked with low level. So cabazitaxel plus prednisolone head-to-head with the mezantrone and prednisolone, and clearly showed an overall survival. However, the risk of febrile neutropenia was approaching almost 4 to 5% in spite of G-CSF support. The trial was positive in second line, so they tried to bring it in the first line in Verstana trial when they look for cabazitaxel at dose of 20, cabazitaxel at dose of 25, and docetaxel, and the matter of fact, it showed there was no difference. So cabazitaxel is still option in the second line and not in the first line of therapy. So the second trial, abiraterone, also was examined post-docetaxel chemotherapy, and it showed clear overall survival benefit of almost 4 months. And again, a VERM trial with enzalutamide given overall survival benefit of almost the same duration of 4 months. Now, we'll go for the radium of T223 Alcemcia trial. Again, patient with metastatic prostate cancer, progression post-docetaxel. get radium-223 or placebo, and again, it showed an overall survival benefits. So if you collect all of this data, the 4 important medication, docetaxel chemotherapy, cabazitaxel, abiraterone, enzalutamide, and radium-223, all of this is valid option as post progression to docetaxel chemotherapy. And actually, we changed the diagram now. For the pre, we can use abiraterone or enzalutamide, docetaxel is standard of care. Then post docetaxel, we have 4 options of treatments. So what about the immunotherapy in oncology? Actually, we have 2 types of immunotherapy that tested in prostate cancer. The first one was therapeutic vaccine, and the second one was checkpoint inhibitors. The first one is Spilocil T, which is again, it is a vaccination that we need to do leukapheresis, take the white blood cells and the macrophage, then inject it again to the patient with adding of ABC gene. And it showed clearly for the patient who's asymptomatic bone-only disease, when they randomized to Spilocil to placebo, they were looking for overall survival benefit, and it does meet the overall survival benefit. However, it was approved in 2010. However, the big concern about this trial, no PSA response, no progression-free survival, no quality of life data, and definitely there is no response. So most of our colleagues in oncology, usually we don't treat patients with Spilocil T. The second trial is Prospect trial, is again is a vaccine that in the last ASCO, published, and again, it was a negative trial with no different in overall survival benefits. Now, the big question is now about the checkpoint inhibitors, and it was tested in a very important 2 trials. The first one was in the pre-docetaxel chemotherapy, and the second one after radiations and radiations to the prostate plus abinumab and post-docetaxel chemotherapy, and unfortunately, we did not find the key for opening the prostate cancer with immunotherapy. Both trials came as a negative trial. So if you look for the all-important trial in immunotherapy, actually, we are very disappointing with the result, and only Spilocil T, and remember, it's to give us an overall survival benefit. However, there is no clinical meaning to the patient, that no response rate, and there is no quality data about quality of life. And PSA tricom was negative, abinumab, either pre or post-docetaxel chemotherapy was negative. So with what we have, this is exactly will not change apart from Spilocil, that we can use it either pre or post-docetaxel chemotherapy. Now, the big question now, we start to understand from our urology that we have something called an M0 castrated resistance prostate cancers. And as a matter of fact, there is no patient till today morning find any case with M0 castrated prostate cancer, even in my colleague everywhere in Saudi Arabia. And there was a 2 important trial for some logistic reason I cannot put the slide. There was a 2 important trial in the last ASCO, and both of them, they test enzalutamide and ablutamide, which is again anti-androgens, with a placebo for patient who has an M0, castrated resistance M0. And in matter of fact, it gives us relapse-free survival benefits. However, we don't have overall survival benefits. So the big question is relapse, progression-free survival. It is surrogate marker as an overall survival benefit. However, ablutamide and enzalutamide is approved. If you can open the NCC guideline, you will find it. So the clinical question, which hormonal and combination therapy, and what about the sequencing, and finally about the biomarkers. So enzalutamide or abiraterone, which one we should use? Actually, there was a lot of trial. Most of them were retrospective analysis, and matter of fact, there was no difference between the 2, that we can use any one of the 2. The only randomized trial that we have with this from Dr. Kim from British Columbia, when he looked for the patient who is treatment-naive metastatic castrate resistance, randomized to abiraterone, then if he progress, we'll give enzalutamide, or enzalutamide, and if he progress, we'll go with abiraterone. And as a matter of fact, there was no difference between the 2 hormonal therapy. What about the combination therapy? There was 2 important trials. One was actually in plenary session of ESMO this year, and they were looking for the ARA-223, which is again, you remember radium-223 plus abiraterone radium 223 showed an overall survival, and abiraterone showed overall survival. So when they combined together radium 223 and abiraterone, it was actually, does not change the overall survival, and the trial was negative. And the second trial, abiraterone alone or abiraterone plus enzalutamide, if the patient progressed on enzalutamide and GSO on this year, and a matter of fact, it was negative. So the idea of combination therapy, it does not seem very optimistic. So what about, and this is the third one, it's actually enzalutamide or abiraterone, or enzalutamide abiraterone does not show much change in terms of the response rate or PSA reductions. So what about the sequencing therapy? The most important thing that we don't have clear evidence. Our phase 3 trial shows the ideal sequencing therapy. Now, what we have actually, it's only some retrospective analysis. As you can see, the number is very low. However, it's clearly patient who's progressed on androgen, they usually did not respond or poorly respond to another one. So enzalutamide followed by abiraterone, or abiraterone followed by enzalutamide, maybe is not the best options. And another important thing, the short time for castrated resistance associated with poor response to subsequent hormonal therapy. Those who progress on chemotherapy within 12 months, usually they don't respond to the hormonal therapy, and maybe chemotherapy is a valid option. Now, if you look for some systemic review as well as some meta-analysis about the discussion about the chemotherapy followed by hormone or hormonal followed by chemo, it seems that the best is going for the chemo, then start with hormonal therapy is maybe the better options. Now, if you look for the FLAG study, which is an European European database, it's again showed that those who have docetaxel followed by cabstaxel maybe is better than to start with docetaxel followed by hormonal, then hormonal therapy. And in the CAST study, it's again the same story that chemo followed by chemo is maybe the best option for sequencing. So the only that we have in our data up to date is the randomized phase 2 was in last ESMO, and basically those who has a poor prognosis, those who has metastatic visceral metastasis, high alkaline phosphatase, or less than 36 months from time of ADT, randomized to cabestaxel or enzalutamide or abiraterone or enzalutamide therapy, and as a matter of fact, there was no big change in terms of the median survival. However, if you can see numerically, it was better with the cabestaxel 6.2 compared to 3.1. However, the hazard ratio was 72 and p-value was not significant. So the summary of sequencing, hormonal followed by hormonal is not the best options, and rapid progressions on docetaxel chemotherapy, it's again not good option to start hormonal therapy. And cabestaxel, it seems it's working regardless of the line of therapy, either second or third line of treatment. Now, what about the biomarker of the last? There was a big discussion about the biomarker, and is there any validated biomarker that we can do? And clearly, our androgen receptor, spilocil V7, those who has a positive, actually, they did not benefit from using of hormonal therapy and compared to taxane therapy. So shall we adapt this in our clinic? Shall we validate? It's not yet validated, and you cannot see it in any recommendations to do the test. Now, what about the BRCA? BRCA, it's a very common in breast. However, now we discovered it's very common in prostate cancer. And the lifetime risk for prostate cancer is almost 13% in BRCA1 and to 35% in BRCA2. And basically, when they look for olaparib, and it was in the New England Journal of Medicine, when they add olaparib to hormonal therapy versus hormonal alone, as you can see, huge difference between the overall survival as well as progression-free survival. However, the BRCA test, the BRCA positive is only 3 to 4% in patients with castrate-resistant prostate cancers. So FDA approved, again, 2 important medication, which is olaparib as well as rocaparib. And basically, both of them now, it's a breakthrough FDA approval for prostate cancer, and there is a currently phase 3 trial about the use of those two medications. So in 2017, you remember castrated resistance, we were only symptomatic or asymptomatic. If he's symptomatic, docetaxel. If he's asymptomatic, abiraterone or enzalutamide. However, in 2018, for patient who is castrated resistance, again, symptomatic or asymptomatic, and for patient who's an M0, enzalutamide plus abiraterone, it is an option for treatment. So, vinyl mab, the castrated resistance. Docetaxel is the initial and the standard of care. And pre, we can use abiraterone, enzalutamide, and after we can use enzalutamide, abiraterone, cabestaxel, as well as the radium, and spirosil can we use pre and post. And you can see the other building is the M0, and basically enzalutamide or abiraterone is an option of treatment. So castrated resistance prostate cancer, it's continuity of improving in overall survival. We can see in the first line, we reach to the 35-month. We reach to the second line, 18 to 20 months. And the third line, actually, we reach to almost 10 to 12 months. And an overall survival for castrated resistance approaching now almost 60 months, with a lot of medications now approved in terms of improving survival benefits. So in summary, prostate cancer, it's a heterogeneous disease, and basically it's not one disease. And the management of prostate cancer is evolving, and every meeting, either in ESMO or ASCO, big meeting in oncology, we find the phase 3 trial or changing practice trial in prostate cancer. Short response to EDT, it seems a good prognostic as well as a predictive for low response to androgen receptor targeted agent. Please don't miss the opportunity or the window for the chemotherapy. I know some of us, we give docetaxel chemotherapy, then we start hormonal therapy until the patient gets sick with the progression, then we add chemotherapy, maybe it's not the best option. So I think the chemotherapy should be hit, docetaxel, cabestaxel, especially in those who has rapidly progressive disease. Personalized medicine, it's not yet approved. However, it seems very promising. And we are still clearly lacking clear predictive marker as well as best sequencing treatment. And in the couple 2 years, we will see more and more of new medication with a new indication and treatment of castrate-resistant prostate cancer. I think with the slide, thank you so much.
Thank you very much, Dr. Abdallah, for this simple, comprehensive, as usual. We will let the discussion after or any question after the end of the presentation. Now we'll move to Dr. Sultan Al-Khatib. He will give us a talk about updates on the role of screening of prostate cancer. Please, Dr. Sultan.
Assalamu alaikum jami'an. Sabah al-khair. I'd like to thank the organizing committee for the invitation to speak about a subject which is one of the most controversial subjects in the last 2 decades. And I would like to start by apologizing for trying to make this subject more controversial because we're still debating whether prostate cancer is indicated or not. So these are the outlines of my talk. First, we'll review the update on the role of the screening in prostate cancer, and then discuss the potential area or strategies to improve prostate cancer screening and early detection. Now, if we look into prostate cancer, and this is a very unique feature of prostate cancer compared to other common cancers, where the incidence has gone through a roller coaster kind of curve that started in the late 80s, early 90s after the discovery and introduction of PSA, and then it jumped high 10 or 15 years after, and then dipped down after people starting to question themselves whether PSA screening is beneficial or not. And after the, in the late 2000s, after the publication of the famous screening trial, the European and the American trials, and the recommendation that came from the US Preventive Task Force, the incidence again dipped down. And now with the update, we will look at this curve 10 years from now and wonder how it's going to look. Another reason for the debate behind whether prostate cancer is screening is indicated or not is that the decline in the mortality did not match the increase in the incidence that happened 10 years from the